I'm audible and visible to all of you. Can you all give me a quick thumbs up if my audio video is fine? Let me just check. Yes. So remember today we are having this as the last session of this month, and in this session I'm trying to cover a lot of MCQs on the one-liners of dermatology. In the morning session also we have done a lot of one-liners. So continuing the same session. So welcome all of you. I hope my audio video is fine. Very nice. Okay. So welcome all of you. I'm Dr. Chesta Agarwal, your NEET PG educator on Unacademy. We provide two type of subscriptions. One is Plus, which give you an access to Unacademy live classes from top educators. You can compete in quizzes and tests, study on the device of your choice, and access to around 25,000 plus questions. Iconic give you an access to both Unacademy and Prep Ladder. Special classes, they are the free live classes. So use the code CHESTA10 and get yourself enrolled. You can watch all the classes and they are very similar to that of paid classes. We have highly effective question bank of 25,000 plus questions. These are some of our top learners who have done very well in NEET PG 21. We have a feature which is known as raise a hand. If you have any doubt, you can just raise a hand. Free calendar, we have a lot of free classes going on the platform. Target NEET PG 2022, very important batch. I request all of you to please be a part of it. We have some offers going on that if you buy a 24-month subscription, 4 months is free, 12 month, 2 months is free, 6 month, 1 month is free. Using the referral code CHESTA10, will give you 10% additional discount. So this is the price list. I would recommend a 6 month of Plus or a 1 year of Iconic if you are trying for the next year exam. Using the course will give you 10% discount on the final price. So please start with the first question of the today's session. Requesting all of you to please answer the question. Anyone? Hysteroid leprosy is a non-nodular diffuse form seen in relapse of leprosy, Fascia leonina, and common in Central America. Now please remember, hysteroid leprosy, it is the leprosy which is seen in relapse of leprosy. So whenever you start the patient on multi-drug therapy, there can be relapse either because of stopping the drug or non-compliance or development of resistance. Both these situations will form or cause relapse of leprosy. And how will these individuals present? Nodular, asymptomatic. We have 5 to 50 or even more nodular, asymptomatic, subcutaneous nodules. So hysteroid is a nodular form, while which is the non-nodular form? It is the luceoleprosy, also known as lepra bonita. Also known as lepra bonita, luceoleprosy or lepra bonita. Clear all of you? Kanya, YouTuber? Clear? Next. Ridley-Joplin classification of leprosy does not include what? TT leprosy, BT leprosy, indeterminate, LL Hansen. Very nice. Now Ridley-Joplin has used 4 criteria. Ridley-Joplin have used 4 criteria. Very, very important. Clinical criteria, bacteriological, histopathological, and what else? Immunological. Now, depending upon these 4 criteria, we have divided the Ridley-Joplin classification into 4 categories or 5 types of leprosy. TT, which is the tuberculoid. BT, which is borderline tuberculoid. BT, which is the borderline tuberculoid. Borderline tuberculoid. What else? What is the next? Anyone? It is the borderline. It is the borderline. Then we have what else next? Borderline lepromatous. And then last is lepromatous leprosy. Lepromatous leprosy. Tuberculoid, borderline lepromatous, and lepromatous leprosy. So which is not included? It is the indeterminate. Now indeterminate is actually the part of Indian classification. It is the part of Indian classification where you have borderline group, tuberculoid group, lepromatous group, tuberculoid, borderline, lepromatous. What else do you have? Indeterminate, Hansen's, and pure neuritic. And the pure neuritic type of Hansen's. Clear all of you? Pure neuritic type of Hansen's. Now Indian classification, it has used only one criteria, and that is clinical. Unlike Ridley-Joplin, which has used multiple criteria. So the correct answer is option number 3, that is indeterminate Hansen. Next question. Swiss cheese pattern of skin lesions is seen in. Where do you see the Swiss cheese pattern? Swiss cheese pattern. Please remember, this is another name for inverted saucer shape lesion, where you have sloping margins and punched out center. Sloping margin and punched out center. Very classical of borderline. Very classical of borderline. Clear? Swiss cheese pattern, sometimes also known as punched out appearance. You may even get a question on this point. Next. Which of the following is not a feature of Lepra reaction? Which is not a feature of Lepra reaction? Which is not a feature of Lepra reaction? Very well done, all of you. Fall in ESR is not a feature. You see raised ESR in any type of Lepra reaction, which is actually an inflammatory reaction. Which is an inflammatory response. So which of the following is not the feature of Lepra reaction? It is the fall in the ESR, which is incorrect. Fever can be seen in both type 1 type 2. This is a feature of type 1 and this is a feature of type 2 Lepra reaction. But fall in ESR is not seen in any sort of leprosy reaction. Another question. Very nice. What is correct about leprosy control program? Please remember the correct answer. The correct answer for leprosy control program is option number 4. Clinical diagnosis alone is used as a basis of instituting multi-drug therapy. Clinical diagnosis alone is used as a basis of instituting MDT. Now please remember the leprosy control program. For diagnosis, you only need clinical feature. For example, if you have to make a diagnosis of Posse bacilli, what are the points required? Skin lesions 1 to 5 or nerve plus minus with negative slit skin smear. Slit skin smears. Okay, negative slit skin smears. While for making the diagnosis of multibacillary, we requires more than 5 skin lesions, more than equals to 2 nerves, slit skin smear positive. Now if you notice, we have OR here. So for making the diagnosis, we do not need any investigation. Pure clinical diagnosis will work here. So this is the only correct statement. Slit smear is not required. In leprosy reaction, you never stop MDT. And thalidomide is the preferred drug, but we are not giving it because it is teratogenic. So the only correct statement becomes option number 4. Kanya, Varsha, Akshat. The answer here is option number 4. Anyone? TNF alpha is strongly associated with TNF alpha is strongly associated with. Now please remember, the TNF alpha is strongly associated with type 2. Very strongly associated with type 2 lepra reaction. Now why it is associated with type 2? Because TNF alpha is the mediator in type 3 hypersensitivity, which is seen very frequently in the patients of leprosy. And it is the thalidomide drug which works on this same TNF alpha receptors, and that is why we consider this to be the drug of choice or the treatment of choice for leprosy reaction. Clear? The correct answer becomes option number 2. Another question. The first line drug includes all except. The first line anti-leprosy drug includes all except. Very nice. We have rifampicin, (600 mg per month), supervised. Clofazimine, 300 mg per month, supervised. And 50 mg per day, unsupervised. We also give Depson 100 mg per day which is unsupervised. So that is the schedule, the anti-leprosy therapy. So rifampicin, clofazimine and dapsone becomes the first line. Thiacidazole is considered to be the second line anti-leprosy drug. So the incorrect statement becomes option number 2. Clear? Anyone with any confusion? Anybody with any confusion? Next. One of the following is the side effect of clofazimine used in leprosy therapy. One of the following is the side effect of clofazimine used in leprosy therapy. Very nice. 3 important side effects of clofazimine is dryness of skin, pigmentation, dryness of skin, pigmentation and intestinal obstruction. Dryness of skin, pigmentation and intestinal obstruction. So the correct answer becomes option number 1. Discoloration is a feature of rifampicin. Malar rash is a feature of dapsone. Macular rash. In a patch of vitiligo, which is correct? Melanin synthesis is inhibited. Melanocytes are absent. Melanocytes are absent. Melanocytes are reduced. In a patch of vitiligo, which of the following is correct? Melanin synthesis is inhibited, melanocytes are absent, melanosomes are absent, or melanocytes are reduced. Very nice, the correct answer is there is autoimmune T lymphocytic damage. Autoimmune T lymphocyte induced damage to what? Damage to melanocyte, causing its absence in the affected part. Another question. Malaria crystallina is because of Malaria crystallina is because of sebaceous gland obstruction, sweat gland obstructions, hair root disorders, accessory sweat glands. Very nice. The eccrine gland it opens directly into the surface of the skin, unlike apocrine which opens into the hair follicle. So you have three sites where you see obstruction: at the level of stratum corneum, at the level of stratum malpighian, and at the level of dermoepidermal junction. At the level of dermoepidermal junction. The obstruction at the level of stratum corneum is known as miliaria crystallina. At malpighian it is miliaria rubra, and at D junction it is miliaria profunda. Miliaria crystallina, miliaria rubra, and miliaria profunda. Clear? So the answer here becomes option number 2. The answer here becomes option number 2. Moving to another question. Very nice, Akshat, Janani, Kanya. Eccrine sweat glands are present all over the body. Except on mucosas like lip, clitoris, external auditory meatus. So the correct answer becomes option number 3. Another question. What is the reliable test for chancroid detection? Skin test, biopsies, gram stain smears, clinical smears. What is the correct answer? Please remember, chancroid is secondary to Haemophilus ducreyi. It presents clinically as multiple painful soft ulcers, also known as soft canker, also known as soft canker. Now what do you do? They have undermined edges. So you just put a probe on these undermined edges and you tend to take a smear. You put a gram stain and you will look a very classical. Can you tell me what is the name of that appearance which you see? School of fish, cluster of joint. School of fish or railroad track appearance. So good doctor, I would only say one thing, that there is no point in getting anxious. It is a normal feature which I think happens to all of you who are giving the exam. But I would recommend all of you to please keep on reading. Try to take a subject which is a little lighter so that you won't feel much stressed before your exam. Clear? Safety pin appearance is shown by safety pin appearance is a very classical feature of donovanosis. You see bipolar bodies or bipolar staining. This is known as safety pin appearance. This is known as safety pin appearance or bipolar bodies. Very classical of donovanosis. Bipolar safety pin appearance or bipolar bodies. Please tell me the answer of the next question. Wife of a truck driver presented with the following lesions. Her husband gave history of penile lesions few months back. What will be the diagnosis? Very nice. This is condyloma lata. Just look at these lesions. They are flat topped. They are like this. And a positive history of penile lesions in the husband. Very classical of secondary syphilis. Very classical of secondary syphilis. Now, can anybody tell me how to treat this patient? How to take care of these lesions? How to take care of these lesions? Anyone? Good. Please remember the correct answer is you will give injection benzathine penicillin 2.4 million international unit IM stat dose, and it is always preceded by a sensitivity test. Very nice. Kanya, Janani, Kavya, very nice all of you. Next question. In which genodermatosis following findings are seen? In which genodermatosis following findings are seen? Janani, Kanya, Iconic. Anybody? In which genodermatosis? Very nice. This is subependymal tumors. Which is a very classical feature of bone villi disease or tuberous sclerosis. What is the classical Vogel's triad? In tuberous sclerosis, you see epiloia, epilepsy, loss of intelligence, and adenoma sebaceum, which is actually angiokeratomas. They are angiokeratomas. Clear? They have other findings like cardiorhabdomyoma, rhabdomyolipomas, dental pit, dental cyst. You can have saltpeter appearance of the skin, shagreen patch, ash leaf spots, etc. Clear? Another question. Patient presents with painless ulcer which bleeds on touch. Anyone? Janani, Kanya, Tariq, Ramya, SB. Now let us discuss a little bit about the ulcers. So genital ulcers can be painless and painful. Genital ulcers can be painless or painful. The examples of painless genital ulcers is syphilis, even donovanosis. While painful ulcers are chancroid, herpes, genitalis. How to differentiate between syphilis and donovanosis? In syphilis, you have hard ulcer, while in donovanosis you have beefy red, exuberant ulcer which bleeds on touch. And that is what is given here. A patient with painless ulcer which bleeds on touch. The answer is donovanosis. Donovanosis. Clear? Clear, all of you? Next question. I want all of you to first look at the image. First look at the image. So much of crusting, thickening is present over the scalp, forehead, cheek. And this patient was referred to us by psychiatric department because she was having some psychiatric illness as well. So any particular association here? The patient referred to us by psychiatry department with the following skin lesion. What is the diagnosis? The correct answer is dermatitis neglecta. Now sometimes what happens, because of poor local hygiene, the skin gets deposited by a lot of keratotic materials. It can be dead skin because there is no bathing, no friction, and the dead skin is not coming out. Very commonly seen in a patient with a psychiatric background. So the correct option is option number 1. Next. Systemic sclerosis, morphia, dermatomyositis, or systemic lupus erythematosus. A 35-year-old patient presented to us with pain. Look at the image. Can you see a very classical pursed string mouth? Anyone? Very nice. This is a very classical case of systemic sclerosis. Now the scleroderma means thickening of skin. It can be localized or limited to the skin, or you can have skin plus systemic involvement. If it is only skin, it is known as morphia. Skin plus systemic involvement, systemic sclerosis, which is further divided into limited cutaneous, where only the few part of the skin is involved, and diffuse cutaneous systemic sclerosis. Diffuse cutaneous systemic sclerosis. So Janani, Shri Ramya, Akshat, very well, each and every one of you. Clear? Next. Organism responsible for this condition will be Coxsackie A16, human herpes virus 2, molluscum contagiosum virus or ORF virus. Organism responsible for this condition. So this is a very classical grouped lesions. Can you see? Now please remember, I don't know whether it is visible or not, there is no umbilication in the center. Janani, there is no umbilication here, and these are vesicles. So whenever you see grouped vesicle at mucocutaneous junction, it becomes a case of human herpes virus 2. Human herpes virus 2. So if you want, I can zoom it again. Look at the lesion. They are vesicles which are present on the penile shaft. Vesicles which are present on the penile shaft. Next. Which dermatome is most affected? Thoracic, lumbar, cervical, sacral. Thoracic, lumbar, cervical or sacral. Please remember, the correct answer is, this is a case of herpes zoster. Here it is on the lumbar area or the thoracolumbar junction, but most frequently it is seen on the thoracic area, followed by cervical, followed by lumbar. Next question. The boy from Kashmir presented to us with the following lesion on the scalp. On doing Booth's lamp, it shows dull blue fluorescence. What will be the diagnosis? What will be the diagnosis? The correct answer is Favors. Now we have T-neck hepatitis, which are of two types. Inflammatory and non-inflammatory. Inflammatory is of two types. Chirion and Favors, and non-inflammatory is black dot and grey patch. Black dot and grey patch. Chirion is the bogey swelling over the scalp associated with scarring type of hair loss. Favors is the deposition of yellow colored cup shaped crust, which is known as scutula. Very common in Kashmirians. In black dot you will see broken hair because of endothrix variety. The spores are present inside, somewhat like this. While in grey patch, it is grey in color because of the lesion on the surface. So you will have dull grey patch on the scalp. So we have inflammatory type and non-inflammatory type. This is a very classical case of inflammatory tinea. Trichophyton Schonleni. Trichophyton Schonleni is the causative agent for this type of fungal infection. Clear all of you? Jiva, Janani, Ramya, Akshat. Moving to the next question. A 40-year-old man presented to you with single anesthetic patch. How will you treat this particular patient? Janani, Trichophyton mentagrophyte do not cause the Favors variety, no. It is more popularly known for Chirion. For Favors, it is the Schonleni variety. Okay? Presented with a single anesthetic patch on the forehead. How will you treat this patient? Now here you can see presence of a single plaque on the elbow. Here. And we have discussed that you have single patch or 1 to 5 patches in a possibacillary leprosy. Now initially we used to give 3 drugs for multibacillary and we used to give a PB kit of 2 drugs for possibacillary. But now we have a uniform MDT where we give 6 months of multibacillary leprosy only for POSI 1 and 12 months of that therapy for the multibacillary type of leprosy. Clear all of you? I hope you understood why option number 3 is not the case. So I'll use this slide and I will tell you. Initially we have two kit, PB kit which includes 2 drugs and MB kit which includes 3 drugs. The old protocol was to give 2 drugs in paucibacillary and 3 drugs in multibacillary. But the new regimen says that you give 3 drugs of PB kit in both multibacillary and paucibacillary. The only difference is here the 3 drugs are for 6 months and here the drugs are for 12 months. So these are the 2 differences which have recently made the changes. Otherwise the kit is same for both these conditions. Clear? Jiva, Ramya, Janani, all my dear students, please give me a quick thumbs up if this is fine. Please give me a quick thumbs up if that is clear to all of you. Now moving to the next question which is on your computer screen. The answer of that question becomes option number 1. Coming to the next question. Now the problem is here. Now this is a patient who is a young female who presented to me very recently, and if you can see that here also we have a lot of lesions which are present. What are these lesions? What are these lesions? A 20-year-old girl living in the hostel develops intense itching in the scalp since a few weeks. Secretion of the hair shaft is taken as shown in the image. What is the correct answer for this patient? Pediculosis, white piedra, dandruff or tinea capitis? Very nice. These are the nits. And where do you see nits? It's a very classical example of pediculosis capitis. We have pediculosis capitis, we have pediculosis corporis, and we have pediculosis pubis. Pediculosis capitis, corporis and pubis. And here it is pediculosis capitis. Another question is on your computer screen. No, it is not dandruff. See, dandruff is not only seen over this part. You can see them throughout the scalp. Second point is dandruff is mainly present on the scalp, not on the hair. You can see in the previous image, the lesions are stick to the hair follicle. Clear? Janani, Pavan, Ramya? Now you have to identify and tell me what is this organism. Identify this organism. I will just zoom this image for all of you to have a look on this image. There is a long cylinder like structure and you can see multiple pairs of digits here. Long structure and multiple digits are seen in this patient. So what is the diagnosis here? Anyone? What is this a species of? No, this is not scabies, this is Demodex. So this is a Demodex species. This is a Demodex species. Clear, Akshat, Janani, Jiva, Ramya? This is our Demodex species look like. Another question is on your screen. Very, very interesting. I request all of you to first look at the image. You can see that there's a blue background and you have pink color organisms which are present. Blue background with pink organisms which are present here. What is the answer? Anyone can answer this question? Identify the organism and the staining methods. Very well done, all of you. This is a very classical Mycobacterium leprae and this is a Zn stain. Now, what do you do in Zn stain? Okay, so we have an image here. To decolorization. It retains the primary color, that is pink color. Now we have live bacilli and dead bacilli, both are seen when you do a Zn stain. Live bacilli is like this. Length is 3 times of breadth. The ends are round. Parallel margins. The dead bacilli is like this. Live is also uniformly stained. So live is very uniformly stained like this. Dead and fragmented. Now I will show you both of them in this image. This is a live and this is a dead. This one is a live. Can you see uniformly stained, parallel margins, round edges? And just have a look over here. Just have a look over here. Dead fragmented bacilli. This is a dead fragmented bacilli which is seen in these individuals. Dead fragmented bacilli seen in these individuals. Clear? So you see both live and dead and the correct answer is option number 1. Next question. Drug of choice for this condition would be drug of choice for this condition would be very nice. Now please look at this image. Can you see a well-defined plaque present unilaterally with clearing at the center and involvement of the active peripheries? This is a very classical tinea menum, which is a dermatophytic species, and the treatment of choice is terbinafine, or the drug of choice is terbinafine in these individuals. Drug of choice is terbinafine in these individuals. Moving to the next question. Anyone? Patient presented with this ulcer over the neck which was asymptomatic. What is the diagnosis? What is the diagnosis? Generally, the dose depends upon the weight of the body weight of the patient. You can give either 250 mg per day or even 500 mg per day can be given. Now here you can see that the ulcer is having bluish margin, deep ulcer, very less inflammation. So this is a cold ulcer, very commonly associated with tubercular leprosy. Tubercular. Keratoacanthoma, actinic keratosis, arsenal keratosis or molluscum contagiosum. Very well done. Please remember the correct answer here is keratoacanthoma, which is also known as molluscum sebaceum. Keratoacanthoma, which is also known as diabetes, presented with the following asymptomatic lesions. What is your diagnosis? What is your diagnosis? Anyone? Very nice. This is a case of granuloma annulare. This is a case of granuloma annulare, which is a necrobiotic disorder or a collagenolytic disease. Collagenolytic granulomas are found. Very classical granuloma annulare. With this we are done with today's session. I hope everyone have enjoyed it. We have a lot many MCQs for everyone, so I'll be continuing this session in the next month as well. I thanks to all of you. Please subscribe to the YouTube channel, that is Let's Crack NEET PG. You can use my Telegram, that is the name is same, Let's Crack NEET PG. If you like this video, please don't forget to give thumbs up to the video. Use my code Chesta10 and get an Unacademy subscription for 10% discount. and don't forget to press the bell icon to get the notification of all my classes. So thank